Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. November is Prematurity Awareness Month. This is championed by the March of Dimes. They report that approximately 1 in 10 babies born in the United States are born prematurely, and this number is even higher amongst infants of different ethnicities and races. Today we will be discussing premature infants and what parents should know about having a baby in the NICU and how using neonatology can improve neonatal outcomes at healthcare centers where they may not have a neonatologist or a neonatal intensive care unit, also known as a NICU. We want to help answer questions you have about having a baby in the NICU, so please send your questions below the Facebook Live comment section and we will be sure to address them the best we can. Joining us today for this discussion is neonatologist Dr. Jennifer Fang. Dr. Fang is the medical director of neonatology program at the Mayo Clinic Children's Center. She's also an assistant professor of pediatrics at Mayo Clinic, and we are excited to have her back today to share her knowledge about premature infants. Dr. Fang, thank you so much for joining us today.
Thank you for having me. It's great to be here.
It is wonderful to be here. You have to excuse my hoarse voice today.
It's that time of year.
Hopefully you'll be doing most of your coffee or most of the talking today, and I will avoid the coughing.
Sounds great.
Okay, sounds good.
Right.
Well, as we mentioned, prematurity occurs in about 1 out of 10 infants. But really, to understand that a little bit more, we need to understand what we consider to be a preterm infant. Can you explain that a little bit more?
Yeah, absolutely. That's, I think, a really important thing to understand is what does it mean if your baby's born prematurely? And really what it is ideally, if you can get through a pregnancy to full term, that's 40 weeks gestation. But prematurity is defined as if that baby is delivered at less than 37 weeks. So at least 3 weeks before the due date. And honestly, prematurity is a range. So sometimes babies are just a little bit preterm, but sometimes they can be extremely preterm. But by definition, prematurity is delivery less than 37 weeks.
Okay. So how early an infant is born may determine kind of where they're going to be cared for, I assume.
That's right.
And there's different levels of care. Can you talk about those a little bit more?
Yeah, absolutely. So generally, if a baby is born at term and is healthy after delivery, then they're able to be cared for in what we just call a well baby nursery or a level 1 nursery. Mm-hmm. And in all honesty, that's oftentimes not really a nursery per se, but they're in the room with mom and working on things like breastfeeding and other things. If a baby is actually born prematurely, then depending on how early they're born, they will likely need additional higher level of care. So if they are, let's say, maybe 6 weeks early or so, down to around 32 weeks gestation, then if they're otherwise doing okay, they can just be in what's called a special care nursery or a level 2 nursery. Typically, though, if they're born at less than 32 weeks and they're very preterm, then they will need an even higher level of care. So those are the babies who do end up needing that critical care in the NICU or neonatal intensive care unit.
Now, not just preterm infants can be in the neonatal intensive care unit. Is that correct?
That's exactly right.
Okay.
So while that may be a large part of the patients that we care for in the NICU, we do have term babies in the NICU that may have other issues. They could have issues with their lungs, with their heart, brain, other things that require them to need critical care.
Okay.
Yeah.
So the rates of 1 in 10, so 10% of infants being born in the United States are being born preterm.
That's right.
That number has increased even over the past decade. Why do we think that the rates of prematurity really aren't improving in the United States?
Yeah, this has been a huge challenge for us in this country. For a while there, for about, I think it was about 7 years, we were actually doing better. Yeah. And we were seeing the rates of prematurity decline. And everyone was so encouraged by that. Yay, that's what we wanted to see. But you're exactly right. For the last 2 years now, 2 years in a row, we've seen the rate of prematurity increase, which is, especially for us in the NICU, is disappointing. And actually, when you look at why is this and what group of babies is this, it's actually not our really teeny tiny, extremely preterm babies. The babies that are contributing to that are actually the babies that we call late preterm. So the ones that are actually 34 to 36. So those babies that are right on the verge, but not quite term. And so it's that group that's kind of driving this increase. Now, we don't know why, but it's that group. And so there's a lot of efforts going on within obstetrics and neonatology, worldwide to try to address that patient population. And what can we do to bring those babies into the term category and keep them healthier at time of delivery and after?
Oh, absolutely. So hopefully in coming years, those rates will be able to decrease as research and more efforts and awareness is put forth.
That's right. Yep, that's the hope.
Okay.
Absolutely.
So the rates or the age that infants are able to be viable when they're born premature has gone lower and lower over the years. Currently, what is an age where you would expect an infant to be able to survive? Yeah.
That is a tough question. There's a lot of things that can contribute to that, but you're right, gestational age is the main one. And generally what we think about is, as low as 24 weeks and definitely 25, we generally, when we talk to parents, will encourage at least an attempt at resuscitation and saving that baby because the outcomes are generally better than 50-50 that baby will survive. Again, that's at 24 to 25 weeks. Now, we do go lower down to 23 weeks and even 22 weeks, which is pretty crazy if you think about it, because that mom is just over halfway through her pregnancy. But we do offer resuscitation at those gestational ages, but it's really important that we do that in partnership with the parents, because we need to talk about what does it mean if your baby is born that early. And not only in the NICU, but getting through and hopefully surviving that time in the NICU, and then longer term as well.
Right.
So people are going as low as 22 weeks at this point, and some people even creeping into the kind of later part of the 21st week. But here at Mayo, we really try to 22 is when we start those discussions with families. 22 weeks. Yeah.
You mentioned some of the concerns and complications that can happen in NICU and life beyond. I want to get into that a little bit later. We have a great audience question about that, so please stay tuned. We'll get to that in a minute. But the things I want to talk about next would be what are some of the risk factors for an infant being born premature for that mother? Do we know, or is it still somewhat unheard of?
That also is, I think, an area where we're learning more. I mean, what leads to preterm labor or, let's say, preterm rupture of membranes? It's complicated and definitely not fully understood.
Okay.
So there's still a lot more to be learned there.
Right.
But that being said, we do know that there are risk factors that moms or, expectant moms should be aware of.
Right.
And one of those is if you've delivered early or prematurely before, you're at risk for delivering early again with any subsequent pregnancies. So moms being aware of their own obstetrical history, really important.
And their obstetrician or high-risk OB doctor would be involved with that, right?
Absolutely, that's right. And that's really important because there are therapies, treatments we can offer those moms to reduce then the risk of delivering early again. So those moms should definitely speak with their obstetrician or high-risk obstetrician about that, absolutely. So we know that, that issue of having delivered prematurely or having a family history, if you have a sister or mom who's delivered prematurely, that can be a risk factor. We also know that if moms are quite young, our teenage mothers, they're at higher risk. And then on the flip side of that, our older mothers, or as our obstetricians like to say, elderly gravida. I don't know where that term came. I was one of them.
Yes, I get offended by that term sometimes.
Yes. So those two groups of moms are also at higher risk.
Right.
And then there's things, that we need to think about if, we're planning to get pregnant is our own health and things we can do to reduce the risk of prematurity. And that's making sure we're as healthy as we can be when we get pregnant. So, things like, trying to achieve a healthy weight before or get near that, because sometimes what drives a preterm delivery can be mom's health. If she develops diabetes during pregnancy or high blood pressure, and other things too, like if you use tobacco or you smoke, trying best you can to quit before, because again, those are all risk factors for preterm delivery. So there's some things that we know about that we can modify about ourselves to try to make that pregnancy as healthy as possible and avoid or reduce the risk of preterm delivery.
At the beginning of the show, I mentioned that there are differences among ethnicities and races.
Yes.
Can you talk a little bit more about that?
Yes, absolutely. So I think this is something that's distressing, I think, to me and to many people in, both obstetrics and neonatology. But if you look at our moms here in the U.S., what we see is that, unfortunately, the rate of premature delivery is higher with certain races and ethnicities, and significantly higher. Like for, Caucasian moms or white moms, their risk is about 1 in 10-ish or so. But for our African American or Black moms, their risk of preterm birth is 50% higher than white moms, which is just, it's crazy. And similarly, our moms, Alaskan Native or American Indians, they're about 20% higher risk of preterm delivery. So absolutely a disparity in the risk of preterm birth based on race and ethnicity. I think there's a lot to be learned about that, because that definitely needs to be addressed so that gap and disparity can be eliminated.
Absolutely.
Yeah.
Well, let's move on to talk about kind of what is occurring while your child is during their NICU stay, while they're growing, while they're trying to get bigger and they're trying to survive that process. Being born premature, does that put them at increase for certain health problems, both in the NICU and lifelong?
It does. It does. Prematurity is one of the biggest risk factors for babies, and it's actually the biggest driver overall for infant mortality. And so, again, that's why it's so important to try to reduce the risk of prematurity. But for our babies in the NICU, they are at increased risk of health problems while they're in the NICU. And that can be things related to their lung health. They're at increased risk of actually developing a chronic or long-term type of lung disease. In the short term in the NICU, they generally need breathing assistance. And sometimes that might even be we need to place a breathing tube and need to put them on a ventilator. Now, where we're at with neonatology now, we really try to minimize the amount of time our preterm babies have that tube in and they're on the ventilator, but they're likely going to need that for our smallest babies. So we have to work on their breathing. The other thing that we work on is feeding. So, a term baby ideally is breast or bottle feeding with mom, but our premature babies, they don't have the skills yet to do that. And so we have to work on feeding them, and that requires us to place a tube that goes from their mouth or nose into their stomach. And then if mom's pumping, which hopefully she is because we love using mom's milk, then we feed that milk to them through that feeding tube. And so they're often on, those tube type of feedings. It could be weeks depending on how early they're born. And I would say the other big thing that we monitor for our preterm babies is they are at risk of bleeding in the brain. And this is one of the more serious complications of being born, especially our extremely preterm babies. These babies have a little fragile area of their little preterm brain that is at risk for bleeding. And so we manage and handle them very carefully to try to reduce that risk. And ideally, they don't have any bleeding in their brain, or it's a very small amount. But sometimes the babies can have larger amounts of bleeding, and that can impact them in the NICU because they might need, follow-up procedures. And again, that can have longer term impact. So when we think about long-term, should we talk long-term?
Yeah, let's talk long-term. We've got a lot of questions about that.
Okay.
Yeah.
So long-term, again, this generally is going to be related typically to how early the baby was born. So our babies who are born the most extremely preterm, they're going to be at the highest risk for long-term health conditions.
What weeks are those?
So that would be kind of our 23 to probably 25, 26 weekers. Okay. Those are the ones we watch so very carefully. And I would say the two big things we watch, one is growth and development. We want to watch these babies as they become infants and toddlers to see how they're doing with hitting all of those developmental milestones, whether it's, rolling over or learning to crawl, or it's starting their first words, because that preterm brain is at risk for, setting them up for developmental delays. So we have to watch them closely, because if we're picking up on that, we're a little worried about language delay or motor delay, we want to get those babies into the right services as soon as possible, whether it's speech therapy or physical therapy. We want to make sure they're getting everything they can to maximize their outcome. I guess the other big thing we look at besides kind of the brain development and development over time, is lung health is another big one. So again, our babies can be at risk for a chronic type of lung disease, and some of them even have to go home on oxygen. And so we watch that carefully too. How are they doing? And generally the good news is for preterm babies, they typically outgrow that. As they get bigger and their lungs get bigger and they develop and mature more, oftentimes, majority of the times, they'll outgrow that. But we watch them, especially this time of year, with all of the viruses circulating. We watch them pretty closely for that too.
Absolutely. NICU follow-up clinic, is that one way that you follow them? I know as a general pediatrician, I can comment on how we follow them. But.
Yeah, so I'll talk about our, and then so we at Mayo Clinic have our NICU developmental follow-up clinic, and our high-risk babies, those preterm babies, follow up in that clinic, and we get them hooked right into there within a couple of months even of them leaving the NICU. And that clinic is fantastic resource for the families too, because when they go there, they see that neurologist or neonatologist who's checking in on them. They get access to our speech therapists, occupational therapists, physical therapists, our fantastic nurses, and our dietitians who want to make sure they're growing, because growth drives development. So it's a fantastic way where we can check all of those things, neurodevelopment, growth, all of those important factors, and we follow them for their first actually 3 years of life. Yeah.
So for families that may not have access to a NICU follow-up clinic, or maybe are too far to travel for that, they're going to have to rely on their primary care provider or their pediatrician who's going to be help following them. So from our perspective, getting them involved with a program called early intervention early on is critical. You know, this is a no-cost program that almost all babies that are born preterm would qualify for. And so they come out to the house. They do physical therapy, occupational therapy, speech therapy later on, and make sure that the child is progressing towards their developmental milestones. And every child's going to meet their milestones at a different rate, and that's the biggest thing I can say to families. Having a child with that delay myself, it's hard not to measure them to a child who may not have been premature or something like that, but just cherish and relish in the milestones when your child are meeting them, and try and stay in the moment and focusing on how your child is doing then. But early intervention is a great program that all communities have to have in the United States, and every state runs it differently in how it's managed, and you can also self-refer for it. So if you are a parent who's listening, it's one thing that you could look to see if your child will qualify for. And moving on, we have some other questions about just being a parent of a child in the NICU. Okay, so let's talk a little bit about that. How can parents bond? We have a great question from the audience. How do they bond with their preemie?
Oh, that is such an important question, because it's so important for the baby and for the parents. But I think, what we look for, and this can be very challenging for our sickest babies in their first days of life. But what we encourage parents, we want them to be present at the bedside. Sometimes if those babies are so sick and they're connected to many support systems, it's hard to do that first hold. We want to do that as soon as we safely can. But if that can't happen in the first few days, you still have the touch, right? They're holding their tiny little hand, hand on the back, things like that, as well as being there. Some parents, will do reading at the bedside to their preemie babies, which is just a beautiful thing to see, especially when you watch that baby's heart rate kind of settle out, and
they know the sound of their parents' voice.
And some parents will have kind of make recordings of stories and have that play for the babies and things. So there's ways you can still be there for your baby and be present even when they're at their sickest state. Then as they they start recovering and we see, okay, now this baby's really hitting their stride and showing nice improvements, then as soon as we safely can, we get them into what's called skin to skin or kangaroo care. And we can do that even if the baby has that breathing tube in, even if they still have some lines. Our nurses, respiratory therapists, they're so good at getting that baby onto that mom or dad's chest and just really snuggling in. And again, I love when I'm walking through the NICU and I see parents doing this, because it's just such a beautiful thing, and they're so comfortable. And again, the babies are just so content. And we know, actually, even from a physiologic standpoint, that the evidence shows babies do better, right? They're all of their measurements look better when they can be doing skin to skin. And for our moms, it's so important, because if they're, pumping and producing milk for babies, that contact helps their milk production increase and meet the baby's needs. So I would say, yes, be there. While we may be your baby's medical team, you're their parents, and we need you and we want you there. And so, spending time at the bedside and doing that skin to skin or kangaroo care is so important. And then because that baby, is going to get healthier, and then they're going to be doing even more. They're going to be the ones changing the diapers, checking the temperatures, all of those things that they'll be doing when they go home. So
fantastic. Okay, I mentioned the term teleneonatology.
Oh my gosh, yeah.
At the beginning, it is a long word. It's a bunch of mumbo jumbo, but what does that actually mean?
Oh, great. So this is a program that we've had here at Mayo now for about 5 years, and I'll be honest, this is one of my passions.
It's your baby.
It is. And so what it is it lets the neonatologist here in Rochester at Mayo Clinic connect via a real-time audio-video connection with our colleagues who are in our smaller surrounding community hospitals. So if we have a pediatrician or a family medicine doctor who's in a smaller hospital and they have a really sick baby get delivered, whether it's due to prematurity or other factors, we can connect with them via this telemedicine and work with them and assist them during these are high-risk, stressful, resuscitations.
Absolutely.
Yeah, and so we work with them to help guide them through all of the important steps to help that care of that baby be the best it can be in the, from the first moments after birth. So, yeah.
We actually have a video about this, and I think you might be in the video.
Maybe a little bit.
Okay.
Yeah.
So I really think it demonstrates visually what's going on, and also for parents who have had an infant who's been premature, you can see what's going on during that resuscitation process that you weren't necessarily there for.
That's right.
So why don't you tell us, set up what's going on here?
You bet. So this is a video of a simulation. So it's not a real baby. So please don't worry. But it's just a little mannequin. But it's a simulation. And what it is you're going to see a local what's going to act as a local care team. So at a small community hospital. So this could be a hospital that only delivers 5 to 10 babies a month, which is actually on the low side. And you're going to see 3 people there who are preparing to take care of what's going to be an extremely preterm baby. What you're going to see is a baby that's probably the size of a 27, maybe 28-week infant, so really small. And then, again, this is a team that doesn't have a ton of experience resuscitating this small of a baby. And then what you're going to see is one of our neonatologists coming in on our telemedicine device and working very closely to help resuscitate this baby and help this baby recover after delivery.
All right, let's take a look.
All right.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic, Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure. I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie.
I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right. And we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our Neo wrap set and ready to go. And I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'll go tend to baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic.
Puts that monitor on here.
We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
And
Heart rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great. It looks like, if you could please, tilt the chin back a little bit. Tilt the head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe 50 to 60 times a minute.
2, 3,
1
breathe.
minute.
2, 3, breathe. 2, 3, breathe. 2, 3.
How's the heart rate, Julie?
Heart rate's still 70.
Fine. I'm not seeing very good chest rise right now, so Lindsay, can you
That's
increase the peak
true.
inspiratory pressure up to 25 for me? How does
Okay,
that feel, Dr. Fang?
we're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks
But
good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Hi. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah. And baby, looks like baby's doing some breathing on his own.
Okay.
That was an excellent video. So tell us, why did you develop this program?
Yeah, so it was actually driven by, you know how we talked about there's disparity in outcomes for moms of different races and ethnicities. Interestingly, there's also differences in outcomes for especially our preterm babies who happen to be born in a hospital that doesn't have a NICU. And so when you look at those babies, preterm babies born in a hospital without a NICU compared to preterm babies born in a hospital with a NICU, those babies born in these smaller community hospitals unfortunately are at higher risk of not surviving, of mortality, and higher risk of serious complications like that bleeding in the brain. And so we were trying to figure out, how do we help those babies? Because, I mean, these are moms who, like, we've had moms that just go into their community hospital, they're like, I'm having abdominal pain. This can't be contractions,
Absolutely.
right?
I'm only 25 weeks.
Right,
Why
like,
would
this
be
can't,
happening?
yes,
Right.
exactly. And then they get there and they're in advanced preterm labor because ideally we actually transfer that mom to a place like Mayo. But if they're that far, they got to deliver locally. And so we're thinking, well, how do we help our colleagues and help those babies and help those families in a better way than what we were doing before, which was trying to help by phone, which is really hard to do. But this way we can be there. We can see the baby. We can work with that team. And I mean, honestly, I've been on these consults for 2 hours while we're waiting for our transport team to get to that community hospital in Minnesota in the middle of winter.
Right.
So yeah, it was just because we know there's that difference in outcomes, and we wanted to be able to help those babies who happen to be born in these smaller community hospitals.
Okay.
Yeah.
So when might this community physician call you guys up? When would they benefit from having this teleneonatology consult occur?
Yeah, that's great. I would, most commonly is for what we're talking about today, which is prematurity. That's our number one reason we get consulted. The other big thing is sometimes babies have difficulty transitioning after, and these are even our full-term babies.
Absolutely.
After delivery, they just have a hard time clearing that fluid out of the lungs, making room for the air. And they show us that by breathing hard, breathing fast, things like that. And so we often get called for those babies who are having a hard time with their breathing after delivery. So whether it's fluid in the lungs, or whether they get an air collection outside of the lungs, or they get, if they pass meconium or stool in the fluid and that gets into the lungs. So those are common reasons that we get called. And then sometimes too, just those term babies who for whatever reason need a lot of resuscitation, a lot of help breathing, then we get involved then too.
Have you guys looked at to see how this program has had an impact on the outcomes of the children who have been involved?
Yeah, we actually just earlier this year published a study. We completed a study because this is what we're trying to do, and we wanted to know, are we having an impact? And so we did do a study, and we looked at babies who had a consult and compared them to similar babies who did not. And what we found was that when that neonatologist can bring their experience and expertise to the bedside with telemedicine, the quality of that resuscitation is better. Which just makes sense. Our family medicine docs are doing the best they can, but they don't do it all the time. So when we can be there and help them, things go better. Whether it's, better breathing for the baby, making sure they maintain a normal temperature, have a normal glucose level, all of those things appear to happen better when we can help out via telemedicine.
Absolutely. Yeah. So what should parents expect to know about teleneonatology if they're going to be involved with it?
Yeah, no, that's really important. I think one of the things is, if you're delivering at, let's say, your community hospital, you can ask. I mean, hopefully everything goes well, right?
Absolutely.
But sometimes it's a question, well, if for some reason my baby needs extra help, do you have this service available? Could you get a neonatologist on telemedicine? Is a reasonable question to ask. I mean, we offer it, and I've worked with other organizations that are starting to develop theirs. And I think the other thing is, the nice thing about this is if we provide a consult, but your baby still needs to come, to the NICU, then we love it, because then we can actually talk to the parents and say, introduce ourselves. Hey, I'm Dr. Fang, and I was just helping out, let's say, Dr. Gregory with your baby, and, we've done everything, but we still need to bring your baby to the NICU. Here's what you can expect. Here's what we've done, and here's what you can expect. And it's funny, because then I've had families come into the NICU, right?
Yeah.
When mom's been discharged, or dad comes in, and they're like, oh, you're the doctor on TV. Well, yeah, I mean, I guess I was. But it's really really nice because we can already start building that relationship with the
Absolutely.
family. Yeah.
Absolutely. Well, this has been wonderful having you here today. Thank you for
Thank you.
sharing all your knowledge about this, answering questions. If we didn't get to your questions during the live video broadcast, we'll be sure to get to them afterwards. Thank you, everyone who watched. You can join us next week at December 6th at the same time, 11 a.m. Central Standard Time. Our next Ask the Mayo Mom video Q&A. We'll be discussing what occurs when infants and children are critically ill and need transportation to Mayo Clinic Children's Center, and how this occurs and who's involved, as we mentioned a little bit earlier in our show, when our neonatal transport teams arrive there. Joining us for this discussion will be Dr. Stephen Gleich, the Medical Director of Pediatric Transport through Mayo Clinic Children's Center and Medical Transport. It's been a great discussion. Please join us next week, and thank you everyone who watched, and have a wonderful day in snowy Minnesota. We send our hellos. Stay healthy and get your influenza vaccine.